number of years ago, you probably remember where physicians were classified as cognitive and non-cognitive. And of all these people, I'm probably the non-cognitive physician who's going to be presenting today. And I'll allude to that a little bit because some of my views on obstructive sleep apnea are perhaps a little bit different. It's been fascinating to me for years to be involved in this, partly because the whole root of this problem is actually very simple. I mean, all this research and all this cardiovascular disease that comes as a result of this is pretty amazing. I'm just amazed about the complexities that this has in the system. But essentially, there's a blockage right here. And the physiology of breathing is that the lungs basically function as a bellows, and as we suck air into our lungs, we collapse it down. In my early days, when I was a medical student, basically treatment for this was tracheotomy, and it was very effective. It helped a lot. Now, I will allude to that as one of the possible treatments of tracheotomy, as especially if people have comorbidities, because I think it's been long forgotten, but back then it was pretty much the standard. So we're going to cover some of the surgical options, and I'll also drop a few tidbits that I think are important for people to remember and keep in mind as we deal with these patients. There's a variety of people in the audience, so I hope I'll address most of your interests. You won't have a lot of graphs and numbers and percentages because I'm the non-cognitive person here. I think that sleep medicine is very much an interdisciplinary business area of medicine, and to that extent I appreciate being invited to this, partly because I think that I am a cog in this big complex medical issue, which is a very huge issue for us. And so in dealing with people, perhaps even the non-cognitive people, I urge you to keep in mind that I think that the people who come in to help you with these problems view this as a multidisciplinary, interdisciplinary approach, and not try to do all of this stuff on their own. I think it's very, very important. I, for one, subscribe to that philosophy, and I hope that people that you work with would also do the same. Probably everybody has seen this at some point in time or another. So we're going to jump right into this. Treatment categories for obstructive sleep apnea. Lifestyle changes. We know this is difficult. We know that actually sleep apnea makes it difficult for some people to change their lifestyles. CPAP, I want to kind of rub this in a little bit. 50% compliance. With surgical procedures, there is no compliance because the operation is done and it's done. They can't not be compliant with that. I'll talk briefly about oral appliances. Oral appliances, I think, have really made their way into sleep medicine. 10 or 15 years ago, it was kind of a rarity to talk about this. Anatomy altering procedures, and I'll focus on this quite a bit, not to make you into surgeons, but basically to kind of explain some of the things that we're doing and why we are doing it and why we're not doing it. And the last will be the hypoglossal nerve stimulator, which is kind of a new animal on the block, and I've not been yet trained to do that. I hope that is forthcoming. The company has been kind of elusive to get a hold of, but we're hoping that is in the near future. The first thing I'm going to talk about is nasal surgery, and I believe that nasal obstruction is probably not a main part of obstructive sleep apnea, even though it probably can, certainly a part of snoring or part of that, but it certainly makes it much more difficult for patients to be able to tolerate their CPAP. Now, as a surgeon, I'm still a strong believer in CPAP. I'm not saying send all your patients over so we can do surgery. I think that CPAP, and I've seen this, some of the research, I've seen some of the reviews and what have you, but also clinically. I mean, I've observed some of these patients. It's absolutely amazing, and I'm probably preaching to the choir because I'm sure you have seen it also. So I'm a strong believer in CPAP, and I'm not trying to draw people away from having CPAP. However, nasal obstruction is a major reason for people stopping their CPAP. And I want to point this out because all this complex research in physiology and how much CPAP helps and what have you, I think it's very common in the long term that people stop using CPAP because they can't tolerate it secondary to nasal obstruction. Now, I don't know how many of you, there was a point where starting people on CPAP was synonymous with starting them on, is this microphone working well here? Or? Okay. Was synonymous with starting them on topical nasal steroids, and I'm not sure that that's being done on a regular basis now, but it's probably not a bad idea. I think anybody who uses CPAP over long periods of time is going to have problems with their nose, and so I'm not trying to generate unnecessary referrals, but I think that people who are on CPAP need to be followed by ENT or somebody who specializes in nasal issues on a regular basis. So I'd urge you to do that. Keep that in mind. It's important. All this work and all this effort that we've gone into getting them to a sleep study, getting them fitted and titrated for CPAP, and then all of a sudden they stop using it. Even years down the line after being successful and being very compliant patients, I see this over and over and over. In all the surgeries and types of procedures that I'm going to discuss, one of the biggest issues is trying to decide which one, for what reason, but a lot of this depends on where their problem is, okay? What is the area of obstruction? And I don't think it's entirely clear where different individuals obstruct. And I think primarily the areas of obstruction are going to be at the level of the soft palate and the base of the tongue. Perhaps there are other areas in children. We see laryngomalacia, how much that really, it certainly increases their effort in breathing. If people have seen children with laryngomalacia, I mean, those kids are really struggling to breathe, and the effort of breathing may have some effect on their physiology as well. But basically, I think, I'm not sure how common or even if it is an issue. I usually talk to patients. Laryngomalacia is usually gone by 1.5 years of age, or at least we don't see the symptoms of it. But are there some weakness of the thyroid cartilage that may persist and contribute to some of this? I don't know the answer to that. Mostly what we focus on in our treatment are areas of the soft palate and the base of the tongue. This diagram shows that here the palate region is outlined in orange there, and then in purple is the area of the tongue, base of tongue, epiglottis, and the lower part of the hypopharynx. These are just some diagrams of what actually happens. Again, during the sleep process, as the muscles relax and the chest being a bellows, they simply suck in the airway and they collapse it down. This is the way I explain it to patients. It's like sucking on a flimsy hose. You just collapse it down. And all of this complex medicine has developed as a result of this very, very simple non-cognitive problem. It's a mechanical problem. A lot of this results from this. Now, in an attempt to classify or find out where the area of obstruction, because based on where the obstruction is kind of where we gear our treatment, or at least our surgical interventions, to be able to help these areas. This is the Mallampudi scoring. I just put it up here because the anesthesiologist used this to try to decide how difficult it is to intubate. But I've been around this business for a long time, and I will tell you that every now and then I have a anesthesiologist saying, oh, this was a class 1, but I can't for my life get this patient intubated. So what you see is not always what we get, and sometimes trying to evaluate and decide where the obstruction is much more difficult than it might seem. Okay, so nasal obstruction probably is not a major factor in obstructive sleep apnea, but it is a very significant factor as far as usage of CPAP, which is key for treatment of obstructive sleep apnea. Both daytime nasal obstruction and nocturnal nasal congestion have shown to be risk factors in labored breathing. Nasal obstruction is a major issue for tolerance of CPAP, and I think I've hammered that point pretty well. Okay, the different types of nasal surgery are basically septoplasty. Let me just tell you that most of you have heard of septoplasty for nasal obstruction. I'm a conservative surgeon, and I think that, I'll just make the statement, I think that nasal septoplasty has been way overrated and way overdone. And one of the things that you can even evaluate your own patients without looking, obstruction that changes over a period of time is not related to the septum. The septum is a fixed anatomic structure. So if somebody did not have obstruction or problems with their nose 2 years ago, and today they're having problems, it's not their septum, okay? Because the septum didn't change. And there's some other structures, and we'll mostly the inferior turbinate, and I'll show you some diagrams a little bit about that. But the inferior turbinate changes on a daily basis. And so you've probably heard of something called a nasal cycle, where the inferior turbinates congest on one side and decongest on the other side, and then they alternate, okay? And that cycle goes between every 30 seconds and every 30 minutes and every 3 to 4 hours. We don't know why the body does this, but we have observed the physiology and we know that that's the fact. But the issue here is that histologically, they're equated to erectile bodies. They're venous lakes that allow the turbinates to go up and down very quickly as a result of a number of stimuli. And so they're very, very dynamic structures. And I think for people who over a period of 2 or 3 years, perhaps wearing CPAP, they start having nasal obstruction, not the septum, okay? So if your ENT doctor says they need to have a septoplasty, I'm skeptical that that's going to work because the septum hasn't changed. The turbinates do change very, very drastically. And so what happens over a lot of years of congestion, irritation, allergies, and what have you, is that these turbinates become hypertrophic. They no longer go down to a baseline where the individual can get adequate airflow through the nose, okay? Repair of nasal valve collapse, and we see this perhaps more in older individuals as our cartilages weaken. The negative pressure from inspiration will tend to collapse the nose down, and that can be an issue also. Perhaps less common. Adenoidectomy, I put it in here just because, and it's not a common thing to do, certainly for adults, but it's something that needs to be looked at, and certainly is a huge issue in children. All right, so here's a diagram of the inferior turbinates, and as you can see, there's not very much air around the inferior turbinates. Now, our physiologists tell us that 95% of our breathing occurs in the floor of the nose. Okay, so that's the area where we need to focus on as far as getting their airway open. And so on your left, you see a congested set of inferior turbinates, and this is after a surgical procedure where they've been trimmed back. And this can be very, very effective, and again, probably what I focus on the most, again, just to make another point, if their breathing through their nose has changed, then it's probably not their septum. I just don't want a lot of people having septoplasties that are unnecessary and not really going to help their situation. These are kind of some clinical examination, and I almost put this to tell you, I put this up here to tell you that it's of little value. The insurance companies have struggled with us for years and years and years trying to have some objective measure of how well a person breathes through their nose. There's a lot of subjectivity on how people breathe through their nose, and you can't tell a lot of times just by looking. Same thing for the septum. I mean, I've seen people with a grossly deviated septum, and I ask the patient, how do you breathe? I breathe fine, doc. I mean, so probably they're not having issues with her septum. Same thing here. I mean, you might see this person all the way obstructive over here, but remember that the inferior turbinates are dynamic. So a lot of it has to do with the patient, you know, their feedback. And so you may put them on topical nasal steroids and they come back 4 to 6 weeks later and say, I still can't breathe well through my nose. There's a lot of subjectivity to this. Again, insurance companies don't like this because we don't have an objective measure of how an individual is going to breathe through their nose. Here's some diagrams about how we repair the nasal valve collapse, and again, not real critical as far as the details on that. Tonsillectomy and adenoidectomy, this is certainly more common in children. My picture is not quite as impressive as the one that we saw earlier, and it's also not my picture, but this is not uncommon. We see this in adults sometimes, and sometimes I'm faced with a dilemma. Patient has a lot of clinical symptoms of obstructive sleep apnea. They come in with tonsils like that. Should I study them, or should I take their tonsils out first and then study them? Okay, because clearly their sleep study is going to be different if we have their tonsils taken out. Insurance companies may not want to cover their tonsillectomy because they don't have the diagnosis of sleep apnea with a sleep study. So this is a dilemma that we face a lot of times. And just an aside, the importance of sleep studies is as we get older and we have some more gray hairs, we get more astute about making clinical diagnoses. And essentially, I'm a clinician. However, with sleep apnea, I've become less and less adept at making diagnosis. And I've been humbled by this type of situation where I'll send them over because we're trying to get the diagnosis of sleep apnea to get insurance companies to cover their surgery, okay? Or snoring, even for snoring. People who come in for snoring, and we're trying to get a small diagnosis of sleep apnea so that they'll cover their procedures, and they come back with an index of 70. And I'm just blown away. I'm just impressed about how inept I am about making the clinical diagnosis of sleep apnea based on a clinical examination and interview. And so it's the humbling business of medicine. And the older we get, the more humbled I am. Okay, so treatment for children. And by the way, in children, I believe that the diagnosis of sleep apnea is 99% clinical, okay? Rarely do I have sleep studies done in children, but sometimes we do call for them. But mostly, I think that parents are very, very good about doing this. Just an aside, I understand that Alaska Native Medical Center a number of years ago, they went through a phase where they would not allow their ENTs to do tonsillectomies unless they had a sleep study prior to the procedure, and that got dropped after a couple of years. So they're not doing that. Again, this is kind of curbside information. All right, the adenoids are basically a set of tonsils that live in the nasopharynx, and it's lymphoid tissue. The only importance here is it's obstructive. It's a mechanical obstruction of the airway, and basically can contribute to nasal obstruction. Uvulo-palatal pharyngoplasty, probably the most common procedure that's done for obstructive sleep apnea. I always tell my patients, I always tell my patients, I'm embarrassed to tell you, but the effectiveness for obstructive sleep apnea over this procedure is 50%. And that's why I said I'm going to poke a little bit fun, because compliance with CPAP is about 50%. So we're kind of in the ballpark, except we're going to put them through a nasty operation. If any of you have ever seen patients recovering from uvulo-palatal pharyngoplasty, it is not a fun procedure to go through. And I make no bones about that. I tell my patients, I tell them what the results are. So why is 50% effectiveness? Why do we have such dismal? As a surgeon, I mean, I'm going to say, we're going to toss a coin and see if this operation is going to work for you. I mean, I'm embarrassed to say that, but that's what it is. And so I think that perhaps patients who predominantly obstruct at the base of the tongue and you trim their palate off, they're not going to get any benefit. And I think perhaps obstruction is not one or the other, but I think it's split up between those two. But a patient who predominantly obstructs at the base of the tongue and you trim their palate off, they're not going to get any benefit. Okay, for patients who obstruct primarily at the palate, and you do a palatoplasty, they're going to get great results. Because we don't have good tools to know exactly where they are obstructing or where they're predominantly obstructing, then I think that I want to focus on both of these issues. Okay, so typically in a patient who has a high apnea hypopneic index, I want to focus on both areas at the same time, simultaneously, and I'll talk a little bit about that. For snoring, however, and actually there was a question in the audience about snoring, you know, I think the approach that we have a lot of times for snoring is dictated by what insurance companies tell you. I think the sleep literature would suggest that there is big effects of snoring on the efficiency of sleep, okay, without getting into graphs and numbers and what have you. And so I do think it is a very important issue. Unfortunately, our insurance companies have beat us into thinking that it's a cosmetic. I mean, they say it's cosmetic, and essentially what they do is they won't cover anything that's quote-unquote snoring, okay? If you put snoring as a diagnosis, they're basically automatically going to deny it. And so some of this is dictated by outside forces, I'm sorry to tell you, because I think snoring is a huge issue. Not to mention the effect that snoring has on the individual and the family. The World Health Organization defines health as physical and mental state of well-being, and this is definitely a mental disturbance for many, many, many people. And again, I'm preaching to the choir, so I'll stop there. LAUP, I don't think is done. I don't think here in Alaska, perhaps in other parts of the country it may still be done, but it's basically a laser-assisted palatoplasty is what that, or uvulo-palatoplasty is what that stands for, and it's basically using a laser beam to create a burn on the palate, which in time contracts and stiffens up the palate. And so, again, for people who have predominant obstruction at the level of the palate, this may be effective. As a surgeon, I like to see the tissue gone. I mean, if we're gonna deal with it, I want to see the tissue gone. This is the picture in the McDonald arches. I'm sure you've all seen patients this way. The little dotted lines on the left there simply indicate where we take the tissue out. If they're tonsils, we extend it down into the base of the tongue and take that tissue out. The limit, I've been asked often, well, how do I know how much tissue to take out? Well, basically the posterior shelf of the palate is a muscular shelf, and that's the shelf that's important. That's the muscle that's important to close the nasopharynx. And so children who have cleft palates have a disruption of that muscle, and they have velopharyngeal incompetence, and everybody knows what that is. But basically, I take out the tissue that's redundant past the nasal, the palatal muscle, and you can't change that. A lot of patients will have a very mild velopharyngeal incompetence after their surgery just from muscle splinting, and that usually will resolve and is not a long-term issue. But that's how much tissue I take out. Take out as much as you possibly can. Will there be some relaxation of the tissue? Well, I think if you go down to the muscle, it's not likely they're going to have a lot of relaxed tissue, but that is one of the things that in time, there can be some relaxation of the tissue. Again, reasons for failure is because I think the obstruction is not predominantly at the level of the palate. The pillar procedure, I haven't done this in a while. Again, kind of my philosophy was that if there's redundant excess tissue, I'm a surgeon, take it out, get rid of it. You don't have to worry about it. There's no issue. The pillars, they're little implants that are put in the soft palate, again, in an attempt to stiffen it up. And this is kind of what it looks like. Just to digress a little bit, sleep hygiene education of the patients is very critical, and I think that all members of the team, need to participate in this. I think patients respond better if everybody, all the way from the receptionist, is encouraging people to exercise, to lose weight, to live a better lifestyle. Counting sheep, be careful when you recommend. I had a patient said, well, I'm really bothered. This is what I see when I'm counting sheep, trying to go to sleep at night. Now for the lower part of the base of the tongue area, there's a variety of procedures, none of which have been 100% effective. Some have been kind of more difficult to incorporate. But the one I want to talk about now is the hyoid bone advancement, and basically it's based on placing a screw in the inner cortex in the center of the mandible and then tying the hyoid forward. And I have a diagram to show that. It'll be a little bit easier. Actually, this is a surgical, I got these slides mixed up. This is a surgical procedure where the hyoid bone is advanced, and it's basically sutured to the upper part of the thyroid cartilage. Okay, so the upper structure right there is the hyoid bone, and you skeletonize that down to the inferior aspect, and you pull it forward and suture it to the anterior structure of the thyroid cartilage. This is the repose system here, where basically you have a screw that's attached to the inner cortex of the very center of the mandible, and then you tie it around either or both to the base of the tongue, and we'll talk a little bit about that, and around the hyoid bone, and then you pull these forward. Okay. The tongue advancement, I've done a number, and I don't quite understand why this is so painful. So I don't do a lot of these, partly because it's very, very uncomfortable for the patients. I've had patients have UPP, which I've already said is very uncomfortable, and this seems to trump all of the procedures. And I don't know why. Maybe it's because I haven't done high volumes of them, but right out of the chute, this was very, very uncomfortable for the patients. It's based on the repose system. I have a little picture of it right here, which is a very clever device. As you see, to be able to get a screw where you can attach a suture into the inner cortex of the mandible, you have this drill. This is a disposable device, and you see how it angles back at yourself, and you can see the little drill right up at the very top there, which comes toward you, which is an unusual configuration, but actually the screw is very easy. The device is very, very creative, and is not hard to use. There's a genoglossus advancement. I always found this hard to do. Basically, you'd come into the anterior port, and that's a little bit out of focus. You come in through the anterior cortex of the mandible, and you take a square of bone out, hopefully getting the genial tubercle and the genioglossus muscle, and then you pull it forward and you twist it 90 degrees so that it doesn't go back in. I haven't done a lot of these, but basically it was promoted, and I'm not sure that it's being done a whole lot at this point in time. But it is certainly one of the options that's out there available. Lower jaw advancements, orthognathic surgery, basically, where something that's called a sagittal split. This is a big operation, and basically it's hard to move just the lower jaw. Typically you have to move the upper jaw, so you have to do a Lefort 1 cut of the upper jaw and move everything forward as a unit, and then wire them together and put plates in. It's a fairly large procedure. So typically these things can be very effective, but they are more advanced procedures usually when other more simple procedures have worked. I'm sorry to say, and even if you look at some of the people from UC Davis who have been very involved in this, I still, from a 30,000 foot level looking at this, there's still a lot of let's do the simple things first and move on up the ladder until we find out what works. I wish we had more diagnostic tools to tell us exactly where the problem is so we could really focus on that. But it's still, in my opinion, there's still a lot of trial and error in the surgical arena as to how to deal with this universally problematic issue. All right, tongue-based reduction, and so this has been very effective. As a surgeon, I still struggle with this because with the soft palate, when I take it off, I see it. Now I don't see it, and so I'm happy. This procedure is basically where you apply a radiofrequency probe to the base of the tongue, and you're relying on tissue damage, which in time will scar and contract, and basically reduce the base of the tongue. It's hard, the base of the tongue is just real hard to evaluate and know how much tissue has been reduced. The research has been done, and it is shown to do that. But as a surgeon, it's just hard to judge. And so when people come back and they have improvement, typically I'll do this in combination with a palatoplasty because I want to address the base of tongue. And so I do this commonly. It's a relatively low morbidity, but I don't know what's helped them more, the base of tongue reduction or the palatoplasty, or what really has been the factor, for them. It does take a number of weeks or months for this to contract, for the scar tissue to contract and become, reduce the volume of the tissue at the back of the tongue. Here's a little diagram of how that works. It's fairly simple to do. It's not hard to do. Tracheotomy, I mentioned that briefly earlier, and basically we bypass this area, which is the origin of all of our problems. When I was a medical student in Oklahoma, basically there were oil field workers. It was very common. That was what people did for sleep apnea. And so the oil field workers would have a kind of a permanent stoma there, and they'd put a little plug in it during the daytime. They go out and they work in the oil fields. They come home at night. They take out the plug and they'd go to bed. And so it worked very well. We bypassed the problem area. And so it's stimulating. I keep thinking that somebody's going to come up with something very clever and something very unique, something very simple that's going to resolve this issue of collapsing somewhere between the back teeth and the upper part of the larynx and resolve this issue. Tracheotomy, I think, now is reserved. It just doesn't ring a bell with people socially. However, well, take a look at this picture. Okay, this is Elizabeth Taylor, and she had a tracheotomy. And I just dug this picture up because I actually met Elizabeth Taylor in St. Petersburg when I was doing my residency over there. They were filming a movie over there. And I knew that she had this scar, but you, in her later years, never saw her neck. Okay, she either had a high turtleneck or she had a $1 million golden tiara or something over that, but you never saw her neck. And the reason was she had a tracheotomy, and she had a horrible scar there, and she had several revisions, 2 or 3 revisions. They could never seem to have an adequate, appropriate, or good results in that. And finally, she just said, "The heck with it! I'm gonna cover it up." And so, this is very unusual. It's the first time I've seen this scar, and I was just digging around the internet and I found that. Dental appliances, and again, I think these have come into maturity. It's interesting, there was some research. Most of the research that we've looked at is focused on AHI, but it sounds like there's some other research that's been going on with this. I think they're good options. I think most people are pretty aware of this, so in discussing options for treatment with patients, I think this is a good thing to mention. Some people just immediately says, I'm not going to bed with a piece of plastic. The same thing they say about CPAP. I'm not putting that mask on. I'm not doing that. That's just not going to happen. I'm going to die from my obstructive sleep apnea. And some people are just really adamant about that. But this is a very effective form of treating. One of the things that we had concerns about, and the issue here, is that we pull the mandible out of its joint, okay? We pull the temporomandibular joint forward. And in the early stages, I was quite concerned. I still think there are an occasional patient who winds up with TMJ problems as a result of altering their temporomandibular joint physiology. So pay attention to that. If you see patients who are having with these oral appliances, I think they need to be monitored for TMJ issues. Certainly can be an issue. We alter their resting position very, very significantly by pulling their jaw forward. And the principle behind this is by pulling the jaw forward, the genioglossus muscle, which attaches to the anterior portion of the mandible, gets pulled forward and advances the tongue, keeps it from falling or collapsing back down into the pharynx. Here's a picture of one of those devices. Here's a diagram of how this presumably works. By pulling the jaw forward, we keep the tongue more advanced and keep it from collapsing down into the hypopharynx. And the last topic, and again, this is new. I do vagal nerve stimulators, so I'm very interested in doing this because it's not. I mean, I think the technique is going to be very much the same or similar, basically in implanting a stimulator. The FDA approved this in May of 2014, so it's pretty new stuff. I've been trying to get a hold of the company. I can't get them to respond. I don't know if they're overwhelmed by people wanting to do this, but I will persist, and we will have this procedure. There's some good research to show that there is benefit. It doesn't remove the obstructive sleep apnea completely. The idea behind this is basically to stimulate. Now, this particular technology, let me go to this diagram right here. There are two leads that you place when you put the generator. It's like a pacemaker, and it's about the size of a pacemaker. Usually I put them a little bit lower in the anterior axillary line, but basically one lead goes to the intercostal muscles, and it senses when the person is going to take a breath, and then it triggers a stimulus to the hypoglossal nerve, which in turn contracts and pulls the tongue forward. And so that's the idea behind this. Again, I think we'll see a lot more of this, or maybe not. I mean, some of the preliminary research is encouraging. Putting these things in is the vagal nerve stimulators. I haven't put a ton of those in, but I'm starting to get better at that. It still takes about an hour and a half under general anesthesia, and you have to tunnel the tissues, and so it's not a. I mean, it's not a hangnail operation. I mean, it's not something you do in the office. But if we're going to get good results, I think this will be a very good option for us to see coming in the future. I'd be very happy to entertain any questions. Hopefully they're not at high levels and talk about too much about troponins and all this other stuff. Yes, sir. I've had a couple of those patients. I do tell my patients, we'll take care of your snoring 99% sure, but rarely we do have people. Now, when I say that we're going to help their snoring, it's a relative thing because we have the roof shaking, door rattling snoring, but we also know that as the air goes through a vessel, it can create overtones and could still create some noise. So part of what I want to know is this related what type of snoring are they having? It's the air going through the vessel. There's not a lot I can do, for that. I've had a couple of patients that are really problematic. I've put the palatal stents in, and it has not really helped them. I've worked on the base of the tongue. I've just got a couple of patients so I can't get their snoring to go away. And so I don't know that there is a magic solution, but fortunately palatoplasty will take care of 99-point-something% of people who snore. Yes? I'm sorry? Well, I don't know. I don't have any experience with that. And I'm not sure that that's actually been looked at as snoring. Again, people don't talk about snoring because it's not covered by insurance. And so who cares about, it's interesting, the vagal nerve stimulator that I'm doing, it's covered for seizures. Insurance companies will not cover for major depression. There's an FDA approval for depression, but insurance companies won't. So I don't get any referrals over for depression, only for seizures, because that's what insurance covers. So third parties dictate a lot of what we do. Yes?
I just want to emphasize echo one point that regarding the major issue coming out, that long-term years is usually majorly determined by the first couple of weeks. And in the same study of thousands of patients that were followed for more than a year, the nasal injection in the first couple of weeks was a major determinant of the adherence long-term. And in my practice, before they go on CPAP, I am giving them nasal stimulants or what have you, to really take care of this problem very, very
Let me just echo that so that other people can hear that. And then basically, the research was done about adherence to CPAP based on their first couple of weeks experience. And if they have a lot of nasal obstruction during the first period, and I just can't tell you much how important that is. And I feel really bad when that happens because we've gone through all this, referral, they've gone to a specialist, and then they had their consultation, and they've had their sleep study, which costs thousands of dollars, and we've gone through a CPAP titration, depends on how the study is and what have you. We get this expensive, wonderful, modern device fitted on them, and they won't use it because they have nasal congestion. So the little things, seemingly little things, are very, very, very critical. I mean, this is a deadly disease, and we need to have success in every step of the way that we go, and this is a very important step. So I thank you for
nerve stimulation. There is a second company that does the hypoglossal nerve stimulation in a tonic way, so that they do not need the sensor in the rib area to look at the inspiration, because it tonically activates the hypoglossal nerve and puts genioglossus muscle in a proactive way rather than a reactive way, which is with the company you just talked about.
We talked about that last night, and I went on the internet to try to find it. I can't find the company, so if you have reference to the company, most of the studies will not mention the companies that have sponsored the study or whatever, but I couldn't find it, and so you mentioned that last night, so we'll look at that, and stay tuned. I mean, we'll hear more about hypoglossal nerve stimulators. We'll definitely hear more about that. Other questions? Somebody had a, yes, sir. Just to repeat, the question is, after UPP invasive tongue reduction, does it affect their CPAP usage? And for some people who have high indices, I will tell them, this may not eliminate your CPAP, but I think it'll make it a lot easier for you to use. And my clinical experience has been, after those procedures, it makes it very much, it makes it a lot easier for them to use their device. And so, if nothing else, I'd like to think they're getting some benefit. And again, I'm not an over-aggressive surgeon, but I don't want to do procedures where they're not going to derive some form of benefit, especially for an uncomfortable procedure like the palatoplasty. But basically, I think that it helps them with their CPAP compliance. It makes it a lot easier. And my clinical observations have been exactly that. Yes, sir. The question is, if I see hypertrophic turbinates on a CT scan, should I refer them? I think that just goes back to say how difficult it is. I might just go back to my medical school days and say I don't treat x-rays. If the patient is not having symptoms or difficulty, if they're using CPAP successfully, no, I wouldn't treat them. But long-term CPAP users, I want to see them, I want to follow them, I want to help them with their nasal issues, because I think it's a very common cause for them to stop using their devices, which is bad. I mean, it was really bad. Yes, sir. Usually nasal congestion, which is not when some of them will start using Afrin, and so then they start getting the rhinitis medicamentosa. But mostly congestion are the main issues. Dryness, even though our CPAP machines have, all of them have humidifiers, a lot of patients don't use the humidifiers. Be aware of that. I mean, they don't like the moisture building up in there, and so they won't use the humidifiers. Even using the humidifiers, the net effect is some dryness on the nasal mucosa. The cilia do not function adequately when they're over dry. It stresses the nose. There's something about it that's not natural for the normal physiology of the nose. And so I work with them, I do local cares, I put saline, I do nasal lavages, we'll have some emollients that I put in there, little things, even sometimes that don't require surgery, but I will be glad to follow them because I think it's very, very important.
I think one of the mechanisms is that sometimes with the use of CPAP, they start to have oral leak. And with the oral leak, it has been shown that it would be more nasal congestion with the cold stuff. So one of the things that may happen is, in fact, the pressure that may need to be changed. And of course, the humidity will help this situation.
So the comment was that CPAP, when they start leaking, they start getting more dryness. And did the microphone come through? Were people able to hear the comment? And that sometimes that might be indicative of the pressure needing to be readjusted. And, pressures maybe need to be readjusted based on nasal congestion. I mean, I don't really know how much nasal congestion has to do with the titration of but the lower we can get the pressure, the happier the patients are going to be.
Really maybe more of a quick question, but perhaps touching a bit on what Dr. Javaheri was referencing. One of my main questions for the hypoglossal nerve stimulation, I spoke with one of the expert consult ENT in the Bay Area, maybe more of the experimental side of things. He was pretty discouraged a few years back in some of the animal studies looking at this, in that the nerve stimulation itself disrupted sleep a bit. And so I was curious if, what has kind of come out. It's obviously been FDA approved, and if you've heard or seen any questions about that.
Again, not having done that, I don't really know. The reviews that I've looked at, I have not seen anything. I've not seen any research to suggest that there's disruption, but I'm sure it'll be more and more scrutinized. And when I made my comments about this, we'll hear more of this as time goes on, or maybe not. I mean, it may be one of those things. But I think people, again, globally, people are thinking of other things. This is a completely new concept or approach to this, so I welcome it. Again, it may not be the solution, but I welcome this. We may find, again, just like a lot of things, even with medications, I mean, they're FDA approved. In time, we find, boy, this had such side effects, so we better pull this off the market. So it may be something that may not be long term, but I think it's stimulating to me to see that there are new approaches and new thoughts on what we can do for this problem, because we don't have the solution yet. And I keep thinking there's going to be something simple that'll come along.